This is your heart, or at least an MRI scan of your beating heart. And as you can see, this small muscle has to keep working 24 hours a day, 7 days a week, 365 days a year, literally until the day you die. When you have your annual physical and you check your lipid panel, your blood sugar, HbA1c, CBC, etc., the truth is that while all these tests are essential and in combination they can give you a picture of how healthy or unhealthy you are, they just won't tell you the real risk about an impending fatal heart attack. You see, the heart has a fatal Achilles heel, a Strait of Hormuz, Suez Canal, or Fulda Gap, whatever you want to call it. Your beating heart has a critical point of failure that many of you don't really know about. Now, if you've been watching this video, you might be aware of more fancy tests and biomarkers for longevity, and I'm sure they're all really great, but I have to cut through the bullshit and get back to the basics of staying alive. And there are 4 tests that I normally do on myself, and the number 1 on the list is the test that gives me peace of mind that I won't die unexpectedly, at least of a heart attack. And I can see you now, you're saying, who the heck is this guy and what the heck is he talking about? If we've never met before, I'm a critical care doctor. I'm the doctor you never want to see. You see, I'm the last barrier between a critically ill patient and the undertaker. I'm the doctor who keeps you alive when you've had a massive heart attack. And finally, if you're in the ICU, and I'm the doctor who is part of the team keeping you on life support. Unfortunately, that means I have seen more than my fair share of death. So that is why I've developed a very intimate understanding of what actually kills people as they enter their 40s, 50s, 60s and beyond. And one thing has become obvious. Many catastrophic events don't come out of nowhere. The warning signs are often there years in advance, and we're just not looking for them in the right places. I've had patients who've had perfect blood tests, no previous medical history, come in with massive heart attacks. Why? Now that's a topic for a different video. What you need to know is whether or not you have a massive heart attack on the cards. Now, I'm going to keep this simple as I can, and by the end of this video, a lot of things will make sense. All that I can give you is my hard-won experience after almost 20 years of being in the business. So let's crack on. The first test on this list is, strictly speaking, not a blood test. It's an imaging study. It's called a CT coronary angiogram. And with that, there's something else called the calcium score. Some of you might have heard of this test before. In order to understand how important this test is, there's just a couple of things you need to understand about the heart. Remember when I said it's got a fatal Achilles heel? This is where I'm going to explain what that is. Now, the heart is a muscle. It beats 24 hours a day. It never stops until you die. Because it's a muscle, it needs energy. It needs oxygen. And where does it get it from? It gets it from blood. And you might be thinking, so it pumps blood, it'll get the oxygen and energy from the blood it's pumping. That's correct to a certain extent. But just like the gasoline engine in your car, it needs petrol or gasoline to run. It comes from a gas tank and is sent to the engine via a fuel line. Your heart has a fuel line itself. And for example, if you cut the fuel line in your car, your engine stops. So does the heart have a fuel line. It actually has a few fuel lines. If you look at the beating heart, you might notice there's these tiny little ridges or folds. You might think it's just a crack in the heart. It's not. They contain something called the coronary arteries, and there is 2 main coronary arteries that we are talking about. One is the left anterior descending coronary artery, and the other one is the right coronary artery. The heart is divided into 2 halves, left and right. The left side contains the left ventricle, which is the most bulky part of the heart, and it's responsible for 75% of the heart function. So the blood actually goes out of the heart through the aorta here, but part of it is sent back to the heart itself via these coronary arteries. And this is where it gets interesting. Now, in this diagram, you can see it a bit more clearly when the heart's not beating. This is that bulky left side of the heart we're talking about that is most responsible for the heart's function. And here are your fuel lines. This is the right coronary artery. This is the left anterior descending coronary artery, also known as the widowmaker. So if there's any blockages in these coronary arteries, what happens is there's no blood flow, there's no energy, there's no oxygen, and the heart starts to die, the heart muscle starts to die, and that's when you have a massive heart attack. So that's why you can see these tiny coronary arteries. They're teeny tiny. Remember, the heart is about the size of your fist. So these are going to be really, really small. And that's why it's so critical to know if you've got any plaque, any clots, any thrombus, whatever you want to call it, anything that's going to block these arteries. And this left anterior descending artery is the one that you ought to be really careful. It's called the widowmaker again. But there is another coronary artery that sometimes maybe your doctor hasn't mentioned to you or you have no idea about. It's called the left main coronary artery, and it sits behind this big blood vessel, which is called the pulmonary artery. And this is what you got to really, really be careful about. And it not only gives rise to the left anterior descending widowmaker, it also gives rise to the left circumflex. So that's two coronary arteries that branch off from there. If it gets blocked, that's the widowmaker's widowmaker. It's almost always fatal. And let me explain this to you in another way. Let's say your heart is like a house. It's got 4 rooms. It's got a bedroom, a kitchen, a bathroom, and a living room. And of course, you have your energy supply or your electricity supply to the house that comes through the wiring system. And let's say, for instance, the electricity gets cut off in the living room. And the living room goes dark, but you can go to the bedroom. And let's say that gets cut off. Again, you can move to the kitchen. This is what your heart is like with the coronary arteries. So it's about 3 main coronary arteries going into the heart. And if you cut them off, fine, you might survive. But then you've got the mains line, the mains power. This is your left main coronary artery. You cut that off, the whole house goes dark. And in terms of your heart, you die. Or at least it'll be as close to a fatal heart attack as you can get if you get a left main coronary artery thrombus or block, and they're devastating. And if you look at this image as well, you can see how thin these coronary arteries are. Here you can see the left anterior descending, the widowmaker. The left main is hidden here. If I can explain to you how small they are, let's take, for example, this drinking straw here. I don't know if you can see it on the screen, but it's a paper straw. We don't have plastic straws here in the UK. If you take this drinking straw and cut it off, maybe about 1.5 centimeters and 0.6 centimeters in diameter. That is the biggest left main coronary artery that I've seen in my experience. Most of them are smaller and shorter in length as well. So that is your critical point of failure. You might be wondering, what the hell am I talking about? Well, I used to work as a cardiac anesthesiologist at one point, and I used to be involved in a lot of open heart surgeries. And I used to always look inside, and when you see lots of hearts in your career, you start sort of comparing things. And I always look at the coronary artery. Sometimes I look at the fat around the heart. Weird things. But the point of the story is the biggest left main coronary artery I've seen is about this size. And as you can see, it's quite tiny. And if you get a clot there, you're done. So all your blood tests, they might predict the risk of getting a thrombus, but it won't tell you if you've already got one. And this is where the test that we're talking about comes into play. Point of all this is we want to see inside here. Your blood tests are not going to show you that. A plain CT scan even won't show you what's going on in there. Now, usually there's 2 ways to see if there's a block in here. The first way is called a angioplasty, and that is a procedure you have normally after you've had a major cardiac event or a heart attack. What we do is we make an injection either in your wrist or in your groin and pass a thin wire all the way up through the arteries, either in your arm or the rest of your body, and that wire gets passed through and it can go into these coronary arteries, and you can inject a dye, and using a form of X-ray, live X-ray, we can actually see what's going on there, and then you can actually put stents using that wire. Now that is a pretty invasive method, and you don't want to do that on your annual physical or even every 10 years or whatever. That's something you don't want to be doing. Now we have a less invasive method, and that is the CT coronary angiogram. So what happens is we inject just one-off injection of a dye. Yes, that sounds invasive, but bear with me. That dye will go through the whole body, and it'll end up in these coronary arteries as well. And then you put yourself through a CT scanner, and these coronary arteries will light up like a Christmas tree. And if there's any blockages, it'll show up, and it's point sensitive, and it's less invasive than a coronary angioplasty. And we can also calculate something called the calcium score. I'm not going to go into detail because I'll be here for hours, but the higher the number your calcium score, the higher your risk of developing plaques and blockages in your coronary arteries. But I'm more interested in actually visualizing what's going on there, and this CT coronary angiogram can definitely show you if you've got a block there, or at least the startings of a block, any narrowings. And then you're on alert. You can then decide with your cardiologist whether you're going for stents or whether you're just going to treat it with medications like aspirin. Now, this test is highly effective at predicting what we call the 5-year risk of getting a heart attack. There was a landmark study called the Scott Heart Trial, which followed 4,000 subjects in Scotland, half of whom had standard heart care, and the other half who had CT coronary angiograms to help guide their care. It was found that the group who had coronary CT angiograms showed a reduction of 41% in heart attacks. This is very significant. Of course, this doesn't mean that the group with scans magically had less heart attacks. It just meant that the coronary problems were detected far more quickly than with standard blood tests, and so these problems were treated far earlier. Now, I first got this test done on myself way back when I was in my 30s, and this was before the Scott Heart study. After seeing a disturbing amount of younger and younger patients coming in for heart bypass surgery, I had to make sure that I didn't have any hidden plaques waiting to strike. And the question of how often to do this test, as it is not something you want to do every year. There's no widespread consensus, but I would say every 5 to 10 years, depending on what you find initially. And of course, you need to consult with your cardiologist to get a proper plan after you've had your tests. And regarding the risks for this test, because it is an invasive test to a certain extent, you are injecting a dye. There is a chance of developing a reaction to the dye, but usually they're quite safe. And the radiation risk is there, but again, it's risk versus benefit. The benefits of finding out whether you've got a clot, I think, far outweigh the risks from the radiation every 5 to 10 years. Now, our next test is called proBNP or NT-proBNP, and it's a blood test for silent heart failure. So silent heart disease is an epidemic. It is estimated that around half of American adults over the age of 40 have some form of hidden or undiagnosed heart disease. And I have seen so many patients come into the ER who've had silent heart failure that's been building up quietly over decades until a sudden and acute illness reveals it, and they end up in the ER or ICU or worse. That is why it is so important to catch it early before there is significant damage. Now, to understand what this test is, you have to understand what exactly is heart failure. Heart failure is, as the name suggests, when the heart fails, irrespective of the cause. It could be due to a previous heart attack. It could be due to something called cardiomyopathy or diseases of the heart muscle itself. It could be from various things, but in the end, all that happens is the heart fails to pump the blood that it receives. And what happens then? So as you know, the heart is a pump. It pumps blood. If it fails to pump the blood that's in it, the blood starts backing up. There's a backup of blood and fluid, and there's excess blood in the heart because it can't pump out everything that's in it, and that happens to stretch the heart. As you can see, this is a cutaway of the heart, and you can see the left ventricle we were talking about earlier, and these muscles get stretched, the heart gets stretched, and when that happens, the heart releases something called BNP, which is actually a hormone. It stands for B-type natriuretic peptide. Previously it was called brain natriuretic peptide. It's sort of a cry for help from the heart. But who is the heart crying out to? It's actually crying out to the kidneys, because there's too much fluid backing up in the body because the heart can't pump. The heart is secreting this BNP, which tells the kidneys to excrete more sodium, more water in the urine, and get rid of this excess fluid. And this is a compensatory mechanism for the heart. It is trying to compensate for the failure that's going on by removing more fluid. And this is really good for us, because this is one of the first or the early signs that you can test for you might be thinking by testing for BNP. Unfortunately, this BNP does not last very long in the blood for us to test, but there is something called NT-proBNP, which we can detect in your blood, and that is a blood test we can use. Now, I use NT-proBNP very often in my practice because it's very easy to distinguish between the symptoms of heart failure and other diseases like of the lungs, which can mimic those of heart failure. Like being out of breath, it doesn't happen just in heart failure. It can happen if you've got respiratory problems or lung problems. So if you can test for this NT-proBNP, it will tell you whether the breathlessness, the ankle swelling, etc., it's all whether it's due to your heart failing or your lungs or whatever. So it's a very useful screening test. Now, if your NT-proBNP is high, you can go for a definitive test, which is usually an echocardiogram or an ultrasound scan of your heart. And this will tell us in more detail what is causing your heart to fail. Then you can get started on treatment before things get worse. But this is a good test, I think, to do if you've got symptoms of heart failure initially, because the symptoms of early heart failure are often ignored as simply signs of aging or being out of shape. If you feel more tired during the day, you can't walk, or you get breathless at the top of one flight of stairs, these are usually just brushed off. These signs are just brushed off as being out of shape. I've done a whole video on how to detect silent heart failure. The link is in the description below. Make sure you watch it after this video if you can. Now, our next test is called lipoprotein A. Now, if you ever had a standard lipid panel or lipid profile done, you might be aware of the different types of cholesterol in your blood. You might be also aware that LDL cholesterol is the so-called bad cholesterol. Now, lipoprotein A, or LPA, LP(a), is like the evil twin of LDL. It is also a type of fatty protein particle that floats in your blood like LDL cholesterol, but it is far more deadly. The risk of having a heart attack is 3 times higher if you have high levels of lipoprotein A, especially in younger people. And if you ever heard of a young person, relatively fit, having a heart attack, they usually have elevated levels of LP(a). And the really scary thing is 1 in 5 adults in the US have an elevated level of LP(a). Now, not only is LP(a) a sign that you're at risk of heart attack, but you're also at a higher risk of having a stroke and having something called aortic stenosis, which is a narrowing of one of the largest valves in your heart. And this leads eventually to heart failure. The other thing about LPA is that it's something that is passed down from your parents. That means it is almost entirely genetic. On the plus side, it means you only need to do the test once in your lifetime. On the downside, there is nothing you can realistically do to lower your levels of LPA. but it acts as an early warning sign so you can keep an eye on your heart health. Now, who should do this test? I would say everyone at least once if you can, but especially if you have a parent or grandparent who's had a heart attack in the past. It's not part of your standard lipid panel, so you might have to request it separately. How many of you test for LDL cholesterol? It's the cholesterol particle that carries a high risk for cardiovascular events like strokes and heart attacks. And that's why we call it bad cholesterol. But what if I told you that even if you have normal or low levels of LDL cholesterol, you might still be at high risk for heart attacks and strokes? This is where testing for something called apolipoprotein B, or ApoB, is very important. You see, LDL cholesterol is not the only nasty cholesterol there is. IDL, intermediate density lipoprotein, or VLDL, very low density lipoprotein, they also put you at risk. So you can have a normal level of LDL but have raised VLDL or IDL. But LDL, VLDL, and IDL all have a common molecule of something called apolipoprotein B. So by measuring just the ApoB, you can measure the entirety of the risk posed by all these small, dangerous cholesterol particles. And that is why I have seen many patients with heart attacks who've said their cholesterol levels, including their LDL levels, have been consistently normal at each annual physical, but maybe they should have been checking their ApoB levels. So these are the 4 basic tests I would do to minimize the chances of an unexpected catastrophic event. They don't cover every possibility, but they do cover the most common causes of sudden death. My intention is not to scare you with this video, but to let you know that modern medicine is evolving at an amazing speed, and all these tests are becoming more accessible, and we have some great tools to help maintain your health. There are 1,000,001 tests for longevity and general health, and they're all really good, but this video focuses just on staying alive so you can have these tests done, and then you can focus on maintaining your longevity and general health. And another reason is that I'm seeing so many health influencers and even so-called many AI-generated fake health professionals just regurgitating health information, some of which can be true, but a lot of it is just ChatGPT generated, hallucinated garbage, and it's causing a lot of mistrust. I just want to relate my own experience and knowledge and try to simplify complex medical topics for you, because you need to be in control of your health. To be in control, you have to understand exactly what's going on in your body. If you like this sort of information, please subscribe. Let me know in the comments if you've had any of these tests done and what you think yourself of these tests. There are many more tests I can recommend, so let me know if you want to make a video about these other tests to do when you hit middle age and beyond. So thank you for watching. Stay healthy, stay safe. I'll catch you in the next one.